With the next presentation, which is how do we ensure correct IOL power and design, which is again very complex, and this is where we have more problems, not only in our hospital but elsewhere as well. I mean, the paper that was written in Archive of Ophthalmology 2018, almost like 2/3 of the errors were related to the IOL, and Dr. Shivkumar will talk about it.
Thank you very much, sir, for this opportunity. I'll be talking about ensuring correct IOL power and design. So, it's not moving. Yeah, I have no financial interest to declare. So in 2023, across the 14 hospitals, we did about 4.5 lakh cataract procedures. And out of 25 sentinel events, 14 of them were related to the IOL, and which means that more than 50% was because of the IOL implantation, and all of them were system failures. Now, this is corroborated by published literature, and we look at two of the papers. This one was already mentioned, and there were 106 errors in the US, which were analyzed, and 63% of them happened to be because of a wrong IOL power implantation or a wrong model IOL implantation. In the NHS, in this paper from between 2003 and 2010, 164 wrong implants were reported. It was considered to become a never event in 2011. However, between 2010 and 14, in the paper, it was reported that 178 wrong IOL implants were reported during this period. So when they did the further analysis, it was noted that between 2010 and 2014, you can see that the biometry error due to technicality had reduced, but the human error had increased with more transcription errors, with the wrong patient biometry data being taken in, with wrong notes being attached, with wrong IOL being selected, and with the right and left eye being confused, and the plus and minus powers being confused. Intraoperatively, it happened because of a change in the order of the list, and also because another IOL was asked for due to a complicated surgery. Again, there were more communication errors, and wrong IOLs were brought into the theater perioperatively, that is preoperatively or in between the surgery. So how do the common errors in biometry happen, which is the main cause for wrong IOL power? So it may be the wrong patient, or for the patient, a wrong eye and a wrong patient document attached to the case sheet. It can be a transcription error. It can be choosing a wrong mode, like Sir showed. Instead of choosing the immersion for immersion, you continue with the ablation mode. Missing the condition of the eye, like having silicon-filled eyes or eyes which have undergone laser vision correction. So let us look at some of the events and the root cause analysis. So patient X came with advanced cataract and underwent right eye IOL surgery, and he came back totally dissatisfied because he had a UCV of 660. This was improving with a -4 diopter to 6.9. So the first thing we did was to look at what was the IOL and what was implanted. We found them to be the same. On further analysis, we knew that the axial length measurement was not possible on the optical biometer, and so his eye was measured with the ultrasound biometer, and then this value was then transcribed into the optical biometer to get the IOL power calculation and to get out the IOL calculation sheet. Then we repeated the biometry and found that in the right eye, the actual power was not +17, but +12. So finding out how this happened, we found that while transcribing the data from the ultrasound biometer, the left eye's axial length value of 24 millimeter was entered in the right eye instead of the actual 27. So we got a power of +17, and this resulted in the error. So the corrective action was to exchange that IOL. And thereafter, we started having the printout from the second biometer, which was used during the time of transcription for checking the transcription, and then attached to the IOL printout so that all this data could be verified. Another patient, Y, presented for left eye IOL surgery, and there was a post-operative refractive surprise of -2.5 diopters. Now, looking at the case sheet, again, we found that the calculated IOL power was 22.5, but the surgery record showed that 25.5 was implanted. So when we did the root cause analysis, we found that the EMR contained 2 separate A-scan records. And when we did the root cause analysis, the reason was that patient Y was measured on the optical biometer, and this data was being transferred to the patient Y's EMR. At the same time, another biometrist measured the eye of patient S and uploaded this also into the open EMR of the patient Y without checking the patient identity. So this resulted in 25.5 being implanted instead of 22.5, because by default, the latest A scan is taken as the correct one, and the printout supplied said that it was 25.5 and not 22.5. So as a preventive action, the EMR was modified to raise an alert whenever one A scan already existed, and the alert would go to the biometrist that already one exists, do you want to upload the second one? In another case, a patient underwent right eye SICS with acrylic IOL, and he came with a huge refractive surprise of -10. Here we found that the IOL power calculated was -6, and when we did the root cause analysis, we saw that -6 was documented in the case sheet, -6 was documented in the total case sheet which went to the operation theater. But when the circulating nurse took it to the OT store, there was a mistake where the IOL supplied was a +6. So there was a human error in reading that -6 were read as +6. The further error was that the circulating nurse did not verify this, and the operating surgeon and the assisting nurse did not verify this, and the wrong IOL was implanted. So for this, a software was introduced, used by the storekeepers, where when the MR number is fed in, it is populated by the patient details and the details of the IOL power and designed to be implanted. And when this IOL is chosen and the barcode is read, it populates the lower half, and the storekeeper can actually verify this with whatever is there in the upper field. Also, if the power varies by about 0.5, then it raises an alert saying that the IOL power is not what is actually advised. Do you want to go ahead with this? So this becomes an alert for the storekeeper to refrain from issuing this particular IOL. So when we look at what happened last year, we saw that there was a wrong manual documentation of an undercorrected power in a pediatric case. Then we had an exchange of the IOL box by the running staff collected in the OT store, just like the example that we showed. There was a patient identification due to exchange of case sheets. This became wrong in about 5 cases. After everything was checked, the unused IOL of another patient was handed over during the surgery. So again, this became a failure. Wrong lens was issued in the store, which was of the wrong IOL power. And in one case, just before the implantation, the IOL had been removed out, and then it was found, before it was from the peel pack, it was found that it was of the wrong power. And luckily, at that last moment, due to the check, the implantation was stopped. And so this was one near miss which happened. In the wrong IOL design, the wrong lens was issued by the store in 5. So basically, the wrong IOL power design was not so much. But even then, the system could not change this. The software could not change this because there was nothing to check the design. It had to be manually checked by the storekeeper. So we can try to address the gap through systems and technology to minimize all these errors. However, eliminating the human component is impossible. So why do we have IOL-related errors more common among the safety incidents in ophthalmology? There are different categories of IOLs, like monofocals, EDOFs, and multifocals. And each of them, in the same category, different brands have different A constants, which may have a difference in power of up to even 1 to 1.5 diopters. Also, there are multiple brands with confusing and similar sounding names. To name a few, something like Vivid and Vivity, or within the same brand, something like Supraphobe and Superphobe. So how do we ensure a safe IOL? I don't have the mouse here, sorry. How do we ensure a safe IOL? So as said before, at every stage, we should ensure that it is the correct patient. We should confirm the name of the patient and use more than 2 identifiers to verify it: unique identification number, the age of the patient, the relative's name, or the address. And also check if the medical record into which any documentation is done is of the patient. For accurate biometry, what is important is a routine calibration at the recommended time. And generally, in the optical biometers, it is done at the start of the day when you start the machine. However, we should be careful to see that the calibration is done. It should be documented. And also that none of these steps are skipped. Again, in optical biometry, we should make sure that the correct mode is chosen, like aphakic, pseudophakic, and the status of the vitreous, like silicon oil filled or not, and whether laser vision correction is done or not. After the IOL power has been determined, the responsibility of continuing with this depends on the OT staff and the store staff. They have to check for the IOL design and power in all the documents available, that is the case sheet, A-scan record, and counseling record, and retrieve the IOL as per these records. And then this retrieved IOL should actually be checked against these case records to make sure that it is the same. And the expiry of that IOL should also be checked. After this, it is issued to the circulating MLOP, and it is handed over to the assisting staff. And while receiving this lens, the assisting staff should confirm the patient identity, confirm whether the IOL issued, the design and the power matches with the patient's medical record, and also check the expiry date of the issued IOL. So to reduce wrong IOL implantation, what are the things that we can do? We should follow the best practices in capturing biometry and in IOL power calculations. So in biometry, we should follow the Holiday criteria, that wherever there is a difference between two eyes of the same patient in the keratometry reading or the axial length or the IOL power calculation, we should go ahead with measurements on 2 biometers and verification by 2 biometrists. And in IOL power calculations, we should make sure that we are using the right IOL formula and we are using the right constants. Only rely on biometry source documents, especially printouts, because we can always verify this with the data, especially if you are transcribing the data, the biometer data, onto the online sheets, like for IOL power, toric power calculation, or for Barrett's formula calculation. Always have a printout attached so that you can always verify that the transcribing was right. Use the cataract safety checklist at all stages, like shown by Madam. Now, the surgeon we as surgeons are the final frontier in avoiding the final error, and therefore we should religiously perform a timeout of verifying the patient, verifying the eye to be operated, verifying the procedure to be done, and the details of the IOL, the model and the implant, and not only before the start of the surgery, but the IOL verification should be done even before the implantation. We should ensure that there is an adequate stock of IOLs so that we do not end up with another model. And we should consider the use of electronic patient records as much as possible, because sometimes in manual documentation there can be problems. If we are using manual documentation, the IOL power should be written in.
Yeah. Can you just finish your talk? Can you wind it up in a minute time?
Yeah, I'll just finish it. Last slide. And consider highlighting which IOL has to be put up, and beware that D can be read as 0 and minus in front of 1 could read as plus. So with all these, with these we can prevent errors. Safety is everyone's responsibility, more so of ours. And if we follow these, then it is possible to reduce all the errors.